Hello again. I'm back to talk about osteoporosis, and this time we're not going to be talking specifically about the perimenopausal woman, but all of the other women who are in your practice, and the need to develop strategies to identify the women who need osteoporosis therapy. And what we're going to be talking about is this tool that some of you are already using called FRAX. This is by the World Health Organization. And FRAX has been out actually since 2008 by the World Health Organization. And subsequently, there have been 3 major updates of FRAX. And there was a major conference, international conference, held in Bucharest, Romania, just this past year in the fall, to address some of the issues, some of the pitfalls of FRAX, some of the limitations of FRAX. So what I'm going to do is try to present to you those who are new to FRAX, how to use it, those of you who are already using FRAX, some of the updates on this and how to use it more successfully, probably individualize it a little bit for your patients. So all of you know that osteoporosis is a generalized skeletal disorder, but the major problem with the osteoporosis is not low bone mass. The problem with osteoporosis is fractures. And 50% of your female patients over the age of 50 will develop such severe osteoporosis that they will have a major fracture. So this is extraordinarily common. Fractures of hips, spine, pelvis, humerus, forearm, and other fractures are all caused by weakening of the skeleton. And if you compare osteoporotic fractures to other serious diseases that your patients over 50 are going to experience, what you can see is your patients are much more likely to have a fracture than they are to have an MI, a stroke, or breast cancer all combined. The problem with osteoporotic fractures is it's hard to get patients and it's hard to get physicians concerned about fractures because many people have fractures, had brothers or sisters who had fractures as children, and those fractures just are kind of a momentary problem. You know, there's pain, you have to have a cast, they heal, you go on about your business. But osteoporotic fractures are different. For one thing, they're costing about $21 billion a year. So that is part of a healthcare budget that we can't really afford. But the personal cost to patients is really much more severe. Patients can develop chronic pain from the deformity of osteoporotic spine fractures. These fractures lead to disability. They're a major cause of nursing home placement and inability to live an active lifestyle. So loss of independence, and both spine fractures and hip fractures lead to premature death. So the real purpose of any intervention with osteoporotic medications is to prevent fractures. And because that is true, the treatment guidelines now have all shifted towards preventing fractures and trying to identify the patient who hasn't fractured yet, who is likely to have a fracture, and then to have more and more fractures because the skeleton is so weakened. And to try to intervene in that progression than it is to just prevent bone loss. So as I mentioned yesterday, we now have 9 effective and very well tolerated FDA-approved medications for osteoporosis. These drugs have been shown to reduce fractures even in patients who have advanced disease. So it's never too late to intervene. Hopefully we're going to intervene at a time where the medications can be more successful because there's more bone and healthier bone still in the skeleton that we can preserve. The problem with osteoporosis medications is the problem with all medications, that there is nothing in life, including all of our medications, that are completely free of risk. And because of the news media, as Dr. Martin said, good news is not news to the news media. It's only the bad news. And the way that the media presents information, patients are becoming more and more concerned about risk. We have become more and more concerned about risk. And many, many people are not very good at assessing the balance between risk and benefit. Now, I mentioned yesterday, and this is just some of the information that supports that overall osteoporosis medications are really quite safe. And if you compare them against the risk of the medications, which in GI, with the bisphosphonates, GI symptoms, osteonecrosis of the jaw, atypical fracture of the femur, very, very rare events. Denosumab, the new medication that we have had for the last year, just some skin eczema really is the only problem, and ONJ has been reported. And then raloxifene has the same risk as estrogen as far on risk for DVTs. This increased risk of death from stroke, but not increased risk from stroke itself, is really very minor concern. And the potential benefits are enormous. I mean, 100,000 hip fractures prevented if we use these medications appropriately, and we could prevent tens of thousands of deaths if we treat osteoporosis. So overall, osteoporosis therapy has a good risk-benefit profile, but we can do better than that by increasing the benefit, by selecting for therapy the patients who are at highest risk for fractures. Therefore, they're the ones that have the most to gain from it, and by maximizing compliance, because giving the medication, prescribing it, is only half of the journey. Patients have to take these medications, and we have data now on bisphosphonate therapy. And even though bisphosphonates stay in the skeleton for a long time, and you would think that if patients were only partially compliant, that the drugs may still work, it turns out that that's not true. You need to take 75% of your medication over a 2-year period to get benefit on fractures, to get benefit that's similar to the benefit that was shown in the treatment trials. So we need to maximize the benefit, and we can decrease the risk. And we can do that by not treating patients who don't need therapy, because they have very little to gain from it, because they're not likely to fracture. And we can choose medications based on the patient's risk profiles. So that's what we're going to talk about, is so that when you leave this conference, you're going to be very comfortable calculating fracture risk for individual patients, understand the benefits of doing that and the limitations of FRAX, and be able to understand how to use clinical judgment along with the FRAX tool to help you avoid some of the pitfalls and to use fracture risk calculations to make decisions about starting and, I think, about stopping therapy. And we'll talk about these updates. So how do you identify the high-risk patient in your practice? There's one question that you need to ask every single patient and document in your chart. Have you ever broken a bone? If so, when? How did it happen? Because patients who have already had fractures are at the highest risk for having other fractures. Now, these are fractures not including the face, the fingers, or the toes, but other fractures, and particularly if these fractures have occurred after the age of 45. So just asking that question, have you broken a bone? So somebody who's broken their wrist and did it with a fall from standing height, for example, even though they say, I fell hard, anybody who fell like I fell would have broken their wrist, that is an indication that this patient is probably at increased risk for fractures and needs further evaluation. And then for the patients who've not had a fracture, then measuring bone density is the best way to identify the high-risk patient. because bone density actually accounts for 60 to 80% of the strength of a bone. So if I know bone density, I have a lot of information about how strong this patient's bones are. And this is why this test is really good. As the T-score decreases, the risk of fracture doubles. So there's an exponential relationship between T-score and fracture risk, and that's why bone density is such an excellent test for identifying high-risk patients. So it is the best early predictor prior to fractures, and it lets you make a diagnosis of osteoporosis prior to the patient having a broken bone. So it was a major advance. But it isn't every piece of information about fracture risk, because it only tells us 60 to 80%. So 20 to 40% of the information about the strength of the bone is something that we cannot measure. So who should not have a DEXA measurement in this? So we have a 65-year-old woman without any other risk factors, a 52-year-old postmenopausal woman, otherwise healthy but has a family history of osteoporosis, a 48-year-old woman, surgical menopause at the age of 38, never taken estrogen, a smoker since age 16, and a 34-year-old premenopausal woman who has just had a tibial stress fracture. Or you can choose, all of these women should have a bone density test. So we're looking for the one who should not, or if you would like to choose 5, you can do that. All right. So the majority of you thought every one of these women should have one, and some of you identified the young woman as not needing, the one with the tibial stress fracture. And I'll show you the guidelines for who should get a DEXA test. Now, these are the National Osteoporosis Guidelines, which say that all women, regardless of risk factors, should have a DEXA test by the age or at 65, and men at 70 and older, and that it's postmenopausal women. There's no guidelines for doing DEXA testing in premenopausal women because we really don't know the relationship between fractures and bone density in premenopausal women. As long as you have estrogen around, your bones seem to be stronger, so that the relationship is not the same between your bone density and your fracture risk in premenopausal women. So those women who are younger than 65 but still postmenopausal should have a DEXA if they have a risk factor for having osteoporosis at an earlier age, which would be low body weight, a family history, premature menopause, and certain diseases like COPD, rheumatoid arthritis, inflammatory bowel disease, are some of the diseases that are associated with premature osteoporosis, or medications like SSRIs, PPIs, antiepileptics, and corticosteroids. So those drugs are associated with an increased risk for fractures and of osteoporosis. So the 34-year-old woman would not have an indication for bone density testing, and so because she's premenopausal, but also because stress fractures are not considered to be fragility fractures. They are overuse fractures, and they are not indications of skeletal fragility. They may be indications of some biomechanical issue or some overuse as far as running or training, but are not indications for bone density testing. Now, once we get the results, we have a lot of information from bone density. Obviously, if bone density is normal, this patient does not need a medication. And the guidelines all say that if the patient has osteoporosis, she should be treated. Now, osteoporosis can be defined by 2 definitions. Either one of them would be sufficient. One is that you have a T-score that's minus 2.5 or below. The other definition of osteoporosis, a clinical definition of osteoporosis, is that you've had a hip or a spine fracture. And if you have a patient who's had a hip or a spine fracture, they, by definition, have osteoporosis. And that's the code that you use for ordering a bone density test if you want to see how severe it is. But you have the diagnosis, and those patients all need to be treated regardless of their DEXA results. So, what about the vast majority, the 34 million women, postmenopausal women, who have low bone mass or osteopenia? So, in ordering DEXA testing, the majority of your patients are really going to fall in the low bone mass category, osteopenia. And that's always been the hardest group to make the decisions. And this is what the fracture risk assessment tool was developed in order to give assistance in making decisions about that group. So FRAX really isn't needed if a patient's already had a hip or spine fracture or if the T-score is minus 2.5 or below. It's only for this group of osteopenic patients. So the guidelines currently state that treatment should be offered to an osteopenic patient or considered if the probability of having a major osteoporotic fracture, and remember yesterday I said that was the forearm, the humerus, the spine, or the hip, was 20% or more, or the 10-year probability of having a hip fracture was 3% or more. Now, what you do need to know is this is not the probability of all fractures, because many of the fractures that patients can have, ribs, pelvis fractures, ankle fractures, lower extremity fractures, those aren't captured in this fracture risk assessment probability. But these are the major osteoporotic fracture risk. Now, the reason for using FRAX is that some of the patients with osteopenia have very, very low risk for fractures, and some of them will have very high risk, and it isn't based entirely on the T-score because fracture risk is determined by more than bone density alone. So your challenge, and my challenge every day, is to identify the patients who are at high risk so that I can offer them appropriate treatment, and to identify patients who are at low risk so I can avoid prescribing medication for them. And I think that is the piece that our patients will appreciate the most, is you're doing this testing to see if you can avoid taking medication and still be safe. So, try this one. Here are two patients, two women, that you are seeing on the same day in two rooms, side by side. 55-year-old has a history of premature surgical menopause at the age of 39 and a past history of smoking. She has a T-score of her femoral neck of minus 2.2. And then there's an 82-year-old woman, otherwise completely healthy, no family history, no prior fracture, and her T-score is minus 1.6. The problem is that neither one of these patients has medical insurance, and neither one of them can afford medication, and you have enough drug for a year in your closet for one. So, here is your challenge. You can give it to the 54-year-old. You can give it to the 82-year-old. You can treat neither of them and save your medication for somebody else. Or you could split it between the two of them and treat both. Most of you said that you would treat the 55-year-old woman, and none of you would split it. I guess I made my point about needing to take all your medication. So I think this is interesting, and let's see if you would make the same decision or a different decision if we use our FRAX tool from the World Health Organization. So what is FRAX? FRAX is a computer-based algorithm. It's very statistically complex, but very robust. It used data from hundreds of thousands of patients throughout the world to assess fracture risk based on bone density and other clinical risk factors. And it combines bone density with clinical risk factors to predict fracture better than either one of those can do alone. And as I mentioned, it estimates the probability of a fracture within the next 10 years for individual patients. It can be assessed on the web right now. It's available at this website that you see here, but you can just go to Google and type in FRAX, F-R-A-X, and what you will get up will be this thing that says Sheffield. This is where the coordinating center is in England. And if you get this page with John Canis's picture there, then you know you've come to the right place. Occasionally, some pharmaceutical company will pay Google, I think, to have their website come up first. So if you get drug information, just back to Google and choose the second. So it will bring you to this page, which is the calculation tool for that patient. In this case, we chose Caucasian. And what you're going to do is you're going to enter the age and the gender. You don't have to put in the birth date. It does have a little area here where you can type in the patient's name or their ID number, which is a very nice thing because many of the HMOs and insurance companies are starting to audit for assessment of osteoporosis and fracture risk. So you can do this, just print it out and put it in a patient's chart. So then you have documented, yes, I've done this, I've assessed this patient. So it makes it much easier for you. So you can enter that. It's not stored anywhere on the website, so it's perfectly HIPAA compliant. Now you need to enter the weight and the height. And for the United States, they give us this little tool here where we can enter it in pounds and inches because FRAX requires that information in kilograms and centimeters. But once you enter the pounds and inches and click on convert, it will actually automatically enter that data in the metric system. And then you need to answer these questions. Prior fracture, has a patient had a prior fracture? All of these are yes, no. They default to no. So if you just look down, the patient doesn't have any other risk factors, then you don't need to click anything. We'll give somebody a prior fracture here, yes. Did the parent have a hip fracture? Yes or no. Is the patient currently smoking? Has the patient been on glucocorticoids? Does the patient have rheumatoid arthritis? Does the patient have secondary osteoporosis? Now, secondary osteoporosis are those diseases and medications that I listed for you as far as the indications for a bone density test. So things like COPD, things like inflammatory bowel disease would be secondary indications. Depression is a secondary cause of osteoporosis. Or a medication like SSRIs, like anti-epileptics, that would be yes answers. But we'll talk about that in a little bit. Alcohol, 3 or more units a day, yes or no. Now you can stop right here without bone density and calculate a fracture risk score for this patient. Now the U.S. Preventive Services Task Force just came out a few months ago with guidelines for bone density testing that say that you need that in order to do a bone density test, women should have the fracture risk without knowing their bone density, similar to a 65-year-old woman without any risk factors. Now that means that if those guidelines could be implemented, that we would not be doing bone density testing in any woman under 65 until we had done FRAX without bone density and found that her risk for major fracture was 6% or higher. Now, there's no way for insurance companies to assess that because there are no ICD-9 codes that would tell them that this is the fracture, this patient has a fracture risk of a 65-year-old woman. So I don't think that these are going to be implemented any period of time. But if they figure out a way to do that, to limit bone density testing for younger postmenopausal women, those younger than 65, this will be how you document that, to do it without having bone density. But if you have bone density, then, which is better, you then put in the bone density and then you calculate the risk. Now, just a few words about how you answered these questions and how FRAX is working behind the scenes. The FRAX really applies to ages 40 to 90. It's meant for postmenopausal women, but there are, like the woman we saw who had an early surgical menopause, could have a FRAX done. If the patient is younger or older, it will default to a younger or older, those ages, respectively. Prior fractures, as we said, is a fracture that occurred, according to FRAX, after age 40, which occurred with little or no trauma. So little trauma is falling from standing height or no more than one step above the ground, without including face, fingers, or toes. Current smoking really means current smoking. If your patient stopped smoking a week ago, the answer to that question is no, because current smoking has an adverse effect on bone quality that is not picked up in the bone density measurement itself. Past smoking definitely increases bone loss, so it will lower bone density, but if you have bone density measurements, you're already picking that up. But it's current smoking has a not measurable effect that we can't see on bone quality. So if you think that patient is going to relapse next week, you can say yes. But so current smoking, it really means that the patient has a new risk factor for fractures. Alcohol, we don't usually measure our own intake in units, but they are approximately a jigger of whiskey, 10 ounces of beer. But the bad news for women who often will drink wine as their alcohol intake, it's really only 3 to 4 ounces of wine for a unit. Almost no one pours themselves 4 ounces of wine. And if you get poured 4 ounces of wine in a bar and get charged $8 for it, you are going to be really upset, because 4 ounces of wine is very little wine. So those patients who tell you, I have a couple of glasses of wine a day, may be getting 4 units of alcohol, not 2. So it's very important to figure out or ask them how big their glasses are. I mean, I have a couple of patients who've gone away from glasses all day. They have their mug of wine, and 2 at night. So systemic corticosteroids, what does that mean? That means oral steroids, not inhaled, not topical, not injected, of at least 5 milligrams a day for at least 3 months, either in the past or currently. So if a patient is currently on them, that definitely counts as a yes if you think they're going to be on them at least for 3 months. If they you did in the past, then that would be a yes. Now, the dose that is assumed in FRAX is a dose between 2.5 and 7.5 milligrams. So if you have patients who are on really big doses of prednisone, this FRAX is going to grossly underestimate fracture risk. So it will be, the calculation is for patients who are on like 10 to 15 milligrams of prednisone a day, that it underestimates by about 25%. Okay, now entering bone density into FRAX. If you look down here, when you go over to enter bone density here, you really, it will say select DEXA. You do that pull down menu and you need to enter the type of machine. There are only 3 types of machines in the US. So you need to choose what type of machine. It'll be on the report. It'll say a hologic, or it'll say GE Lunar, or it'll say Norland. And then you want to enter femoral neck bone mineral density. And that comes from the report here, but that will say neck BMD in grams per centimeter square. Put that into your, to the little box there, and then push calculate. Now when you do that, the T-score may be different than the T-score that you see on your report. So in this case, this patient's T-score was reported as -2, and on FRAX it's -2.2. And the reason for that is FRAX is calibrated to use a specific NHANES database for femoral neck bone density that is not used by all of the manufacturers. So it's very important that you do this. Now, you could, if you don't have this information, go down and put T-score and enter the T-score. But you will be wrong much of the time if you do FRAX on black women, for example, because FRAX is actually calibrated to look at a T-score that was calculated using a young, normal, white database. And many of the manufacturers use a black, young, normal database to calculate T-scores for black women. So it's most of the time you'll be very close with your white women. If any of you happen to see men, you will be wrong all the time with men, because none of the manufacturers use young, normal, white database to calculate T-scores for men. So it's safest to just use the bone mineral density, and then FRAX will calculate the correct T-score for you. Okay, so here is the answer. 55-year-old woman with a T-score of -2.2 has a 10-year risk of a hip fracture of 1% and a major osteoporotic fracture risk of 8%. She's actually in a very low risk group at the moment. She is very far past her menopause. We talked about that yesterday. She's past that rapid loss of bone because, remember, she had a premature menopause at 39. So she's already lost that estrogen packet. She's losing bone probably at about, maybe at the most, about 1/3 of 1% per year. And that might be able to be slowed down or prevented by calcium, vitamin D, and exercise alone. So for the next 10 years, this woman has a very low likelihood of having a fracture. The 82-year-old, however, has a 3.7% risk of a hip fracture, 13% risk of a major osteoporotic fracture, and she meets the guidelines for therapeutic intervention. So FRAX can make a big difference in who we choose to treat. I don't think that you are wrong to consider therapy in the younger woman who's got a T-score of -2.2. She's close to the osteoporotic range, but I don't think there's any urgency to treat her. And it's very possible that you may be able to manage her for the next 10 years with calcium, vitamin D, and exercise, and then use medications when her fracture risk is higher because she has gotten older. So this helps us make those kind of judgment calls that aren't intuitively very clear. The other benefit is that FRAX, I think, can help guide the choice of treatment. And it can help patients make better decisions based on their improved understanding of the real risk and the real benefits of treatment versus no treatment. So here's another patient for you to consider. 72-year-old woman, history of a wrist fracture at age 65. Her mother had a hip fracture, and when we calculate her FRAX scores, she has a 30% chance almost of having a major fracture, 11% chance of having a hip fracture. So she clearly is at very high risk for having fractures. This is somebody I don't think anyone would have much of a problem deciding to treat her. So which medication would you prescribe for this woman? Would you give her raloxifene, calcitonin, or bisphosphonate? Or denosumab? Okay. So almost everyone, except for one person, would give her raloxifene, which is a drug that's FDA approved for the treatment of osteoporosis, not just the prevention of bone loss. But most people would give her a bisphosphonate or denosumab, and based probably on the fact that this woman is at high risk for hip fracture. And only the bisphosphonates, alendronate, risedronate, and zoledronic acid and denosumab have been proven to reduce hip fractures. So these are the only FDA medications we have that we know reduce the risk of hip fractures. And that's a very serious disease for this woman. And her risk for hip fractures is going to just increase exponentially as she gets older. So these are the right drugs for her because it gives us kind of global fracture protection. Now, teriparatide, or PTH, is the only anabolic agent that we have. Probably would not be most people's first choice because it's injectable. It costs $7,000 a year. So this is not one that we use that much. And in this patient, whose bone density is -2, lowest density is -2.0, would not be the first choice. But we actually think it probably reduces hip fractures, but we have no proof of that. And the reason we think that is because it reduces the risk of all non-vertebral fractures. And if you look up here, it's the drugs that reduce non-vertebral fractures that had bigger studies that went on long enough that showed hip fracture protection. So she started a bisphosphonate. She tolerated it very well, but she now is back in your office saying, I want to stop this because my dental hygienist told me that my jaw was going to rot. And how dare you give me this medication? So here are your choices. Would you stop the bisphosphonate and use calcium and vitamin D alone? Would you switch to another drug like raloxifene or calcitonin, which don't have proof of hip fracture reduction, or would you do something else? Okay, so the majority of you would do something else, like run, I don't know. But actually, something else is the right answer because this woman does not have the information she needs to make this decision, and neither does her dental hygienist. What you need to be able to do is to educate this woman and to reassure her. Now, that's easier said than done, is it not? To reassure her about this. And this, I showed you this yesterday as a little preview. This, I think, is the most helpful piece of paper in my office because I can, and you can do this with, if you're more computer literate than I am, you can actually plot a patient's their own fracture risk, assume that the benefit that they will get from fractures at least a 50% reduction because that's what the studies show. And then you have these estimates of fracture risk, of other diseases. So, you know, here we have osteonecrosis of the jaw. We're talking about 0.01%. And these atypical fractures we talked about, 0.5%. And compare them to things like the risk of being murdered in the next 10 years, the risk of having a fatal motor vehicle accident. Ask your patients if they're going to stop driving their car, because driving their car is much more risky than taking the bisphosphonate to rot their jaw. So it helps patients put into balance what the risk of not taking medications. That's what they don't appreciate. They're afraid of medications, but they don't calculate in what's the risk of not doing something, of avoiding medications. Now, the FRAX is really meant to be a guideline, not a rule book. These are just to help you, and of course, in certain circumstances, I mean, you're certainly free to advise patients to take medication or not take medication based on other issues. And you do need to individualize them because there are some limitations and pitfalls in using FRAX. One of these is this: garbage in, garbage out. And now FRAX has come to most DEXA machines. So most of you will start to see the FRAX calculations on your DEXA reports. Now, somebody is asking the patient the questions, and it depends on whether they're getting the right information. And I can tell you, we do 800 DEXAs a month at our facility, and we have yet to figure out how to determine if somebody really has rheumatoid arthritis. Because that's one of the questions. It has a major effect on the FRAX calculation. And what we do now is we don't accept the patient's statement that they have rheumatoid arthritis unless they can tell us a specific medication that they took for rheumatoid arthritis. So we're very careful about not including rheumatoid arthritis, but I can tell you 95, 99% of all DEXA facilities and radiology practices will not do that. So you have to look at the report to make sure that the patient's risk factors, which should be listed on the report, actually belong to that patient. Because I've had patients come to me with FRAX scores saying, I said, you had a fracture. And you go, oh, no, I never had a fracture. I didn't know what that was. So I just said yes. So you really have to make sure that that information belongs to your patient. Also, FRAX was designed and it was calibrated for patients who weren't on therapy. As soon as you put a patient on medication, their risk for fractures drops. And it drops very quickly. There's no place on FRAX to say this patient is on treatment, and therefore the FRAX estimate that you're getting is going to be the estimate of their risk if they weren't on treatment. So you know they're on treatment, you know that their risk is low. Now that's going to be a problem because patients are going to expect their fracture risk to decrease when they go back for their next DEXA. If the facility includes the FRAX estimate, it'll be exactly the same, right? So it really is important to keep that in mind. So it will overestimate fracture risk if the patient is really taking their medication. But I think there is a role for using FRAX in patients on pharmacologic therapy. I mean, the NOF has been trying to get the manufacturers not to allow FRAX calculations if patients are on medications. But I actually think that for the educated physician, this can be very helpful. So let's look at this patient, 55-year-old woman, menopause at 45, taking alendronate for the past 5 years, wants to know how long she has to continue treatment. So if you take her baseline FRAX score, -2 of her hip, femoral neck, no other risk factors, and you calculate her FRAX now. Now, this woman met NOF guidelines a few years ago. This was the guideline to treat everybody who had a T-score of -2. But now the guidelines have shifted to looking at fracture risk and this woman's risk for fractures in the next 10 years without medication, 7% for major fractures, 1%. Would you have treated this woman to begin with? Probably not. Does she need long-term treatment now? Does she need to be on for longer than 5 years? No. So this makes a very good case for trying to go back and make decisions now. And you saw yesterday where 2 years of alendronate given early in the menopausal transition, if somebody had been treated early menopause, might be enough, or at least enough for quite a long time. until you monitor, and then when she starts losing bone again, or her bone density drops down to the point where you would want to be treating her, then you can reinstitute treatment. So I think FRAX can really help you, and it can be very reassuring to be able to say, your fracture risk now is very, very low. You don't need medication now. We're going to monitor you. We'll follow you. When you need medication again, if you do, it gives patients motivation to stay on their calcium and vitamin D, to be good about their exercise, so that they don't ever have to take that drug again. So are there times when FRAX gives us the wrong information, when it underestimates fracture risk? This is very important, and yes, it does. If we don't enter all the risk factors into FRAX, if FRAX underestimates the impact of a risk factor, or the risk factor is actually just not even included. And I'm going to go through these fairly quickly. 65-year-old woman, history of past smoking. She says she's shorter now than she was in the past, but she's never had any back pain. She doesn't have any kyphosis. She has no history of fracture. She takes calcium. She takes vitamin D. Her T-score is minus 1.8, and her FRAX score is 13%, major fracture risk 1%. So she's not she doesn't meet the NOF guidelines. So what would you do at this point? Would you start an osteoporosis medication? Would you ask her to continue calcium and D alone, or would you do another test of some type? So most people would advise her to can just continue on calcium and vitamin D. She's at low risk. Let's just keep doing what you're doing. We'll follow you. But 7 of you wanted to do another test. And I agree with the 7 of you who wanted to do another test, because there's one test that's missing here, and it is a measurement of height. And even if patients don't tell you they're shorter, you need to measure their height. This woman had lost 2 inches of height from her peak height, what she thought she was when she was a young adult, and that should prompt some kind of lateral x-ray, or either by the DEXA machine or by just standard x-ray, to look for vertebral fractures. And in this case, she has 2. So what is her diagnosis? Osteoporosis. She no longer is a low-risk patient. She's a very, very high-risk patient now for new fractures, for hip fractures, for more spine fractures, for being disabled, for ending up in a nursing home or dying. So vertebral fractures are the most common, but they are also mainly silent. Only 1/3 of them ever come to clinical attention. So you need to measure height every year in your women over 50. And if the patient has lost over 1.5 inches since what they thought they were when they were young, or if you can document a 0.8, these are guidelines that came up with by the International Society of Clinical Densitometry. But if you document height loss, get a lateral spine x-ray or image, because that may be vertebral fractures and the patient needs treatment. Now, what about the FRAX underestimating? Because certain risk factors like heavy smoking, heavy alcohol intake, if the patient has had more than 1 fracture, or if the patient's been on more than 7.5 milligrams of prednisone, like we talked about, their risk is higher than FRAX will estimate. So this is where clinical judgment, and FRAX doesn't adjust for the dose. So you have to adjust, and the times that this will be important is when the patient's fracture risk is kind of in the middle. It's more than 10%, but it's not 20%. Then you have to mentally say, okay, this patient may have a higher fracture risk. And there are certain diseases and medications, the ones that we talked about, like diabetes and depression and epilepsy, which increase fracture risk, but aren't in FRAX. Again, when you see a patient like that and their fracture risk is kind of intermediate, these may push you over to offering therapy. And falls is a big one of these. But none of these, you would think that there's this little place where you can put in secondary osteoporosis, right? So FRAX is taking this into account. But in fact, FRAX assumes that all causes of secondary osteoporosis, all of these diseases and medications work by reducing bone density. So if you calculate FRAX with the bone density entered in there, FRAX ignores the answer to this question because it thinks it already has that information, and therefore it just doesn't take it into account. However, if you calculate FRAX without using bone density, then it will take this into account. But then you've lost the information from the bone density, which is a really important and part of accurately estimating fracture risk. So you have to do this mentally. This is part of clinical judgment when using FRAX. Now, falls is a really big risk for fractures. Really, really big, right? However, is the answer alendronate to falls? So in a patient who's falling or engaging in risky behavior, then you're going to underestimate fracture risk, but the intervention may be more directed towards preventing falls. But again, in patients who have reasons like MS to be falling, then you're going to have to kind of add that into their fracture risk. So just one more point. FRAX is totally spineless, which means that it only considers femoral neck bone density, not the spine bone density. And look at this patient. Here's a perimenopausal woman. Her spine T-score is minus 2.4, and her hip T-score is actually a plus 0.3. Her FRAX score will be very, very, very low, right? So you have to pay attention to the spine because the spine actually affects the risk for spine fractures. Hip density predicts your risk for all fractures, like non-spine fractures, and your risk for hip fracture the best. But the spine density predicts your risk for spine fractures. And this woman is heading south because she's perimenopausal. So if you just use FRAX on this woman, you would miss an opportunity to really help this because a 10% drop in her bone density would have her be minus 3.3. So this woman would be in serious trouble. So is FRAX the answer? It is a help, a major help in making treatment decisions of people with osteopenia. I think it can help you a lot. We use it all the time now. You will get, if you start to use it, you will actually get to the point where you'll be able to do FRAX in your head more often than not, and know that patients are at very, very low fracture risk and don't need therapy at that moment. But clinical judgment is far from obsolete. So no risky behavior in you or your family,